welcome. I am Robert Smith, Associate Professor in History, and I direct our Center for Urban Research, Teaching, and Outreach. Today, folks, we're not going to hear from epidemiologists. We're not going to hear from economists. We're not going to hear from the all too important voices that are coming to us from various public health sectors. What we want to do today is give you a chance to hear from some social scientists and some humanists to provide an analysis of this current moment through the lenses that our experts here today are able to articulate some very important ideas and indeed provide some thought-provoking questions about where we are with COVID-19 here in Wisconsin. So please join me in welcoming Dr. Sameena Mulla, who is an anthropologist over here in Marquette University, Dr. Mike McCarthy, a sociologist, as well as Dr. Phil Rocco from the Political Science Department. And we're gonna jump right into it. We have an hour. We know that the Zoom process has its limitations, so we wanna make sure to jump into this conversation right away and get us going and keep us into and around the hour mark. So Dr. Mulla, can you please get us started with some of your commentaries and some of your thoughts about the impact of COVID-19. Ladies and gentlemen, Dr. Sameena Mulla.
Hi, thanks for inviting me to the conversation, Rob. I'm going to talk today very generally about why COVID-19 has impacted Milwaukee so intensely and go over some kind of health basics. So Ben, if you can move us to the map, which is the next slide. Probably a lot of us are familiar with this map that is color-coded to show where the most cases are in the state of Wisconsin. So yellow is the highest number of cases. I pulled this map on Wednesday, and so those two white spaces are Taylor and Langlade County, and they're now light blue as well. So all counties in the state have reported cases. And we all sort of have a sense that we're not seeing even reports of cases of COVID-19 across the state. So I want to talk a little bit about why that is. And if we move to the next slide, I have two rather obvious, but I think important basics to start with. And one is the nature of COVID-19 itself, which at this point we've all heard it's a novel virus. What does that mean? It means that it was likely being transmitted among animals and then jumped to humans sometime in the last 12 months. We're not exactly sure when that happened. So we don't really know how it behaves in interacting with human beings. We thought the symptoms were one thing. That picture is changing every day. The second thing we know about COVID-19 is that there are some patients who are infected with the virus and they're completely asymptomatic. They don't have any kind of obvious symptoms at all or whatsoever, or they may have very minor symptoms. And when you have a virus that can spread asymptomatically like that, it can really infect large communities of people. So it's a very invisible virus, and this will make it stand out in contrast to something like Ebola, which our most recent Ebola outbreak was in 2017 in West Africa, and it's actually much less contagious in many ways than COVID-19. And the third thing that we are fairly certain of with COVID-19 is that it has an outrageously long period of being contagious. So when folks hear that you can shed the virus for up to 10 days or 2 weeks is one that we hear quite often, it means that people are infectious for a really long time. And so it's, you know, the first person, I think we're feeling all kinds of feelings now, that we turn to blame is not a person, is in fact, it's the nature of the virus itself makes it very challenging to take on. And when we look at the map, we also understand that it's the nature of cities themselves that lead to higher rates of infection, that quite honestly across the entire nation, what you're seeing is the most population dense areas for the most part seem to be where we're seeing the highest number of cases, just based on the fact that it's human to human contact, right, through respiratory droplets that leads to these high infection rates. We also know that cities have really high levels of social inequality, and that social inequality contributes to health inequalities. And I'll talk a little bit more about what that means. But with our larger populations in cities are places that have services, so we tend to have numerous communities that depend on lots of different services. There's a lot of diversity, and where you have inequality, you tend to have generally more illness, okay? Now, there is a silver lining, which is that the characteristics that make cities vulnerable are also their greatest bet for effective and innovative response. Some of my other colleagues will talk about what kind of responses, right? So while we're sitting here thinking about why Milwaukee is bearing such a heavy burden when it comes to these infections, we can also think about all of the innovation that is going to result from the relatively larger public infrastructures that we still hear, the healthcare networks. If we talk about where hospital beds are in the state, we are going to see rural Wisconsin really needing to count on some of these resources as we have to relocate patients, right? What you're looking at now is in fact the confirmed case count by race and ethnicity, and this is again as of Wednesday. And this is overall from March, pulled from our health services dashboard. So this doesn't have a dynamic quality, but what you might notice is that on the highest column indicates in Milwaukee County that the highest number of cases are among Black patients in the city. The second highest column is Hispanic or Latino, and then the third highest column points to our white patients. And there, some major disparities we start to notice there, and it's important to understand those. And Ben, if you can forward to the death counts, which is the next slide, you'll see again that in fact the death counts are also overrepresented among Black patients. And we need to remember that in terms of the total demographics of the county, while these are fairly even numbers, in fact our white population is much larger than our Black and Latino population. So seeing these sort of raw numbers of deaths and cases really indicates that there's great overrepresentation of those patient communities within these racial and ethnic populations. So I'm going to talk a little bit about health disparities now, because I think it's very tempting always, particularly when we're dealing with a pandemic, where there's a lot of unknowns, right? The science of COVID-19 is changing on a day-to-day basis, and we don't know a lot more than we did probably 6 weeks ago, right? We still don't have a vaccine. We still really don't have an efficacious treatment that has met any kind of scientific standards of wellness. So we're kind of left with our fears and uncertainties. And I'm an anthropologist, so really looking into those kind of cultural components of pandemics, I think, becomes key, because it becomes very tempting to say, well, what is it that this group of people is doing that makes them sicker than other people? And I think that that is a really normal human response, but I want to urge us all to kind of resist that particular response, because in fact, when we think about health and how we experience health and wellness and how it's distributed over different communities, the way we approach it as social scientists and also in biomedical sciences really means taking into account the kind of ecology of health around you, or what we refer to as social determinants of health. So Ben, if you could move ahead to the next slide. This is Artiga and Hinton's 2018 version of explaining social determinants of health. One of my colleagues at the Medical College of Wisconsin likes to explain it simply by saying, listen, anytime you're working with a patient, 10 to 15% of your overall health and wellness is completely in your control. And the remaining 80% or 85% has to do with all of these other things, like Do you have access to healthcare, the healthcare system? Do you have community support? Do you have access to food and medicine? Do you have access to education? Do you have access to a safe neighborhood and physical environment? And are you experiencing economic stability? And it is so easy to look at these kinds of social determinants and still kind of weaponize them against individuals who are, you know, quote unquote, making bad choices. But as social scientists, when we think about healthcare intervention, we recognize, again, it's much more powerful to intervene at the level of the social determinants of health. So if we're talking about a city like Milwaukee, which we know has a lot of segregation, we've all seen the lists every year that get published. We understand that wealth inequality tracks very much in Milwaukee more than other cities with race. So resources haven't been equally distributed. And so what that means is that communities that were already underserved in terms of healthcare coverage, in terms of social support, access to clean water and food, are going to feel greater and more devastating impacts. The other thing that we're going to see is that some of us now have a choice. I'm a university professor. Stay-at-home orders meant that I could teach my classes like this from Zoom at home, right? And still continue to make an income. Many of my colleagues and people in other lines of business found themselves laid off and now facing choices about what kind of essential work they could engage in. And so essential workers are going to find themselves continuing to not be able to make choices about social distancing, for example, and that burden won't be equally shared across all sectors of the community. So can I have the next slide, Ben? Thank you. Some takeaways before I wrap up. I got one more slide after this. What are the main things that I want folks to take away from understanding social determinants of health? I think I want to be really clear that when we think about racial and ethnic disparities and also class disparities in levels of COVID-19 infection, I want to be really clear that it is not biology that makes a particular community unhealthy. As bizarre as it is to say that, it isn't. It is in fact the social environment. Because health is distributed at this structural level, what we have seen pandemic after pandemic is that essentially individual behavioral intervention does not work at the late stages of the pandemic. That ship has kind of flown, and so you do need to think about large-scale intervention, okay? We have to remember that some community members have much more limited choices they can make about their health. And we also have to think about how this health inequality ultimately impacts us all. We're all dependent on those essential workers to make it possible for all of us who are able to social distance to continue to. And we're also all relying on the same healthcare networks. So I want to move to my last slide, and then I'll wrap up. Some other things that are quite particular to Wisconsin is that we know that we have an exceptionally high rate of incarceration. And our prisons and jails are located throughout the state. And there have been, now we start to see higher levels of COVID-19 infection among these custodial communities. Congregational communities refers to people who are in, for example, assisted living facilities and things like that. So we're also an aging state. And 22% of Milwaukee County's population, or more actually, are 55 or older. And we know that aging and also being in a custodial community or a congregational community makes you more vulnerable to COVID-19. I think it's tempting here to also think or imagine that somehow those outbreaks don't impact us individually, right? And this is also not good system-based thinking in part. I mean, I think there are plenty of ethical and faith-based reasons to also attend to the question of why custodial and congregational communities should be protected from COVID-19. But if that doesn't convince you, which it doesn't some people, I think it's important to remember that outbreaks in custodial and congregational communities actually intensify the health crisis everywhere. I think some people think that jails and prisons have their own healthcare facilities. They do not. Prisoners are transferred to nearby hospitals where they will continue to drain down or require, I should say, intensive care facilities, which are very few and far between. If we think about like one of our largest facilities in the state is Chippewa Valley, right? So Eau Claire and Wheaton, and the Mayo Clinic facility in Eau Claire has at regular capacity 26 beds in its ICU, right? And the Chippewa Valley prison has, I think, 450 beds in it for prisoners. And so in these close quarters, we really need to think about how we can get ahead of outbreaks in these kinds of facilities, because they're going to impact both residents of these facilities, and also we do have correctional staff who are becoming sick and going home and going grocery shopping and doing all the things that people need to do. And so these situations are not contained within those particular settings. So I think I'm over time. I'm going to wrap it up there. But on the last slide, I did want to say again that it's going to really require a lot of creative thinking, cooperation, and collaboration in order to come up with creative solutions to navigate the pandemic. I'm going to pass to Mike, who's going to talk more about some of the economic considerations.
Thank you, Sameena. We really appreciate that. We want to certainly encourage our attendees. Don't forget, you can drop questions in the Q&A feature and or the chat feature at any time. We'll get to those questions as needed. We certainly appreciate the opportunity to think about this particular moment with the pandemic and a much longer history as it relates to these kinds of crises. And so we appreciate your comments there, Dr. Mulla. Mike, if you can take us into your conversation. Ladies and gentlemen, Dr. Mike McCarthy.
Thanks so much, Rob, and thanks so much for having me here today. I'm going to talk a little bit about the factors that have really made this a social crisis around the world, and some factors that I think are going to make it a crisis that lasts beyond just the health risks of COVID-19. And you're going to see that there's quite a lot of overlap between what I'm about to say and what Dr. Mulla just said. The health emergency has really contributed to a social crisis. Now, most of us that are kind of following the news will have seen that the stock market has been going, up and down quite crazy, and even financial assets that are typically seen as quite secure, like U.S. Treasuries, their prices have been quite volatile. But the social crisis is not financial, merely financial in character. Instead, it's really one that's been disproportionately carried on the backs of working people, not elites, not professionals like those of us on the panel. Working people that are really being torn apart by unemployment, by food and housing insecurity, and by exposure to the virus. According to the Bureau of Labor Statistics in April, the unemployment rate in the U.S. Rose to 14.7%, and that in fact is an underestimate. It's probably closer to 20%. And Goldman Sachs has recently put out their estimates saying that we're going to reach at least 25% by the time this thing is over. If you look at it from a global perspective, the IMF, the International Monetary Fund, is predicting a massive slowdown in global growth over the next few years. Working people around the world are facing a massive downgrade in their quality of life. Now, some of us policymakers sometimes view this picture in kind of rose-tinted lenses. They think that if we simply lift social distancing orders, that everything will return to normal. And a lot of the narratives out there that you might see, particularly from the Trump administration and Republicans, is that we'll have something like a V-shaped recovery. Right now, we've kind of gone into a crisis, but as soon as this is kind of dealt with, everything will go back to normal, just as quickly as COVID-19 came. But I want to try to make the argument in this short talk today that is that is not a correct view. That is kind of a delusional view, and that actually the things that we're seeing, the current social crisis that we're seeing, is not merely the result of the pandemic itself, but rather it's a result of deep social inequalities that pre-existed the pandemic and deep problems within the global economy that are being worsened by it. So I'm going to talk about basically three different preconditions for this social crisis, conditions that I think are really going to have really worsened it, the way it's playing out, and will probably make it last beyond simply the health emergency that we're facing with respect to the spread of the virus. The first kind of set of conditions I want to talk about is the weakness of working people around the globe in terms of their ability to organize in unions, their ability to make demands, their ability to get safety gear, and so on. The crisis that we're seeing right now is really widening class cleavages around the globe. And were it not for these inequalities, it would be unfolding in a much more manageable and much fairer way. On the one hand, if you can kind of look at the slide here, it kind of gives you a picture of what I'm about to talk about. Those workers that have already been laid off in such high numbers are precisely the ones already from the most precarious parts of the labor market. If you look at Bureau of Labor Statistics, basically we have this kind of interesting statistical finding here. If you look at the average hourly earnings in April, they shot up rapidly. They increased by 8%. It's not that people are getting paid more. It's that lots and lots of people that are getting paid poorly are getting fired from their jobs, right? So we're seeing basically the poorest, most precarious people on the labor market, the ones that are basically losing their employment. On a global level, there are already over 200 million unemployed worldwide, and the International Labor Organization is expecting that during the second quarter of 2020, over the next 3 months, 6.7% of global working hours are going to be cut, leading to an additional 195 million job losses globally. And of course, the hardest hit are going to be in the informal sectors of the developing world in places like Brazil and Nigeria. In India, for instance, there are nearly 400 million informal workers that are at risk of sinking into a deeper level of poverty. And these are precisely in the places that are kind of concentrated slums where diseases can spread quite rapidly. So on the one hand, we see this massive loss of employment for poor and precarious workers. On the other hand, the workers that are being asked to continue on working in the essential sectors, putting their very lives on the line, are disproportionately drawn from the same precarious sectors of the workforce. Think about the McDonald's or healthcare workers that don't have proper PPE. With the exception of well-paid medical professionals, most of the workers being exposed to health risks are the ones already on the bottom of the labor market. Now, we don't know the exact numbers because of reporting, but the CDC reports that about 11% of all COVID-19 cases in the US are healthcare workers. We also see inequalities in citizenship, in gender, and race, all being deepened in kind of the class terms that I'm talking about. In the fields and factories that grow, pick, slaughter, and package the foods that we still find in our supermarkets, many undocumented workers who are uninsured because they're on migratory work schedules have been deemed essential. So adding health risks to lives already forced into the shadows. 1 in 3 jobs that are held by women in the US have been classified essential, with non-white women more likely to fill them. And as disparities widen at work, they also widen at the home. New York Times reported an interesting statistic. They found that nearly half of all fathers that are staying at home with their children, like I am currently, say that they're doing the majority of the homeschooling, whereas 3% of mothers staying at home agree with that. So there seems to be a added burden going on in the workplace. Sameena talked about some of the death statistics and how those have been unequally distributed. That's also true on a national level, along racial and economic lines. But the key thing that I'm trying to sort of key point I'm trying to make here with the focus on class is that those carrying the burden of the crisis are overwhelmingly already the poorest. And in the US, the weak systems of welfare and social support, eroded really since the 1980s, have only served to worsen the problem. And our already broken and fragile social safety net has not been enough to secure people that are falling out of the labor market. 1 in 5 children under 12 right now don't have enough food to eat, for instance. And estimates suggest that 15 million more people in the US are going to sink into poverty this year. Thousands around the country, you can see long lines around at food banks are trying to get a meal, while recent reports on May 1st show that 107 food pantries across the country have closed because they didn't have enough resources, didn't have enough people to provide the work there. So this is basically this crisis is deepening the already fissures that we have in our society. Now the next kind of precondition for the crisis that we're seeing is the health system in the U.S. The American health system is a fragmented one and in part privatized. And without the guarantee of treatment found in really every other rich democracy, a lot of people don't have the protections that they need to affordably fight the disease if they get it. And medical firms and state governments have not allocated enough resources to adequately respond to it. As you can see from this picture here, more than half of all the counties in the U.S., which have about 7 million people above the age of 60 living, which are at-risk folks, have no ICU beds to put folks in if they get sick. If you could go to the next slide, Ben. In the United States, about half of all U.S. residents get their health insurance through their jobs, through their employers. And according to a recent report by the Kaiser Family Foundation, in the downturn so far we've seen, nearly 27 million people lose their medical insurance because they've been fired. Now, about 12.7 million of those folks are going to be eligible for Medicaid, and about 8.4 million are going to get subsidies through the Affordable Care Act, which are still going to leave them with large bills. But 5.7 million of those workers that have already lost their jobs have been left without medical insurance. So our private healthcare system is not adequately responding to this crisis. Now, it's turning a profit boom for healthcare and pharmaceutical industries, but it's been, much more of a struggle for the people that consume those goods and the people that work in those industries. According to the Bureau of Labor Statistics report in May, which I just cited, 1.4 million healthcare workers have been fired from their jobs, which is kind of extraordinary since we're in the middle of a healthcare crisis. And those consumers that have been unlucky enough to get sick are getting hit with massive bills. Some people are on the verge of bankruptcy because of them. So those are the first two factors I wanted to point out: the class inequalities that have pre-existed the crisis, and the health inequalities in terms of access. But I want to talk a little bit now about how COVID-19 is worsening underlying problems in the global economy that actually preceded it. And the effects of this are likely to extend the jobs crisis beyond the health threat of the pandemic itself. Now, around the world, in response to this crisis, central banks and governments have really acted very quickly to try to ease liquidity stresses by increasing access to cash and credit to both firms and citizens. But we're now already entering a second phase of the crisis, and that is a crisis of debt. As revenue dropped rapidly because of social distancing declines in demand, there was a rapid increase in credit that was needed mostly for firms, but also for ordinary households. Initially, this kind of influx of credit that the Federal Reserve and the U.S. government did through the stimulus package was kind of seen as a bridge to get us over this crisis. But the credit bridge really might be only one in appearance. As one of the Federal Reserve governors, Lael Brainerd, has argued. He said, quote, "Forceful early interventions have been effective in resolving liquidity stresses." That means like firms can't get cash. But we will be monitoring closely for solvency stresses among the highly leveraged business borrowers, which could increase the longer the COVID pandemic persists. So the thing that actually is helping firms and households make it through these tough times could serve to deepen them and actually make them worse in the long run. If you could move to the next slide, Ben. And this is kind of all about debt. Since the global financial crisis of 2007 and 2008, high leverage, basically taking on debt, has served as a magical way for firms to increase their profits. In 2007, it was banks, if you remember the subprime mortgages, that were over-leveraged. This time, it's also non-financial firms in the global economy, whose global indebtedness rose 13% between September 2008 and December 2019. These firms were already, prior to COVID-19, holding down the wages of their employees and slowing down reinvestments in a real production of things in favor of upward redistribution to their executives through things like stock buybacks and allocating money into mergers and acquisitions. If you could go to the next slide there. We have some recent research by Baines and Hager that find that small and medium-sized firms in the US have had profit margins since the early 2000s that have been in the negative on and off. And if you're wondering who are small and medium-sized firms, well, small and medium-sized firms that have less than 500 employees, employ half of all the people that are employed in the US. So it's like a very large percentage of our economy. And what they found is that in order to keep themselves alive, these firms have been taking on more and more debt. They've been borrowing more and more cheap money because interest rates are so low. And they describe these firms as zombie firms who are kind of feasting on debt to stay alive. If you can go to the next slide there. So we've basically seen debt to revenue ratios of all firms increase. The top 10%, these are like the large major conglomerates, but also small and medium-sized firms, which have seen their debt to income ratios increase at the most drastic amounts. According to the Federal Reserve in May of 2020, in their financial stability report, in addition to stock market volatility, this corporate debt threatens to worsen the crisis and actually extend it beyond COVID-19. On debt, the Fed suggests, quote, "The strains on household and business balance sheets from the economic and financial shocks since March will probably create fragilities that last some time. Financial institutions, including the banking sector, which had large capital and liquidity buffers before the shock, may experience strains as a result." Now, that's a lot of financial techno jargon, but here's the essence of what they're saying. The basic risk that threatens capitalist political economies around the world right now is that as firms become more and more indebted through these stimulus packages and cheap credit, and are unable to make the revenue in the real productive sector to pay back those debts, default rates are going to increase, right? In such an event, more and more firms are going to go into bankruptcy at the same time that credit markets are going to freeze up because of the risk associated with lending. People don't want to give money to people that are not going to pay it back, right? And so these massive expansions in credit that we've seen essentially since 2007, they've reached $9 trillion globally, could be a gigantic bubble that is burst by this current health crisis. And if that happens, with more people unemployed and without credit globally to pay for things, there are real risks of going into an even more dramatic collapse unless we have a serious policy response. So while we often think about what's going on, at least in terms of popular reporting, as a crisis that's simply caused by COVID-19 that's going to be gone as soon as COVID-19 is gone, the real threat is that we won't have a V-shaped recovery, but we'll rather have a U-shaped recovery, or worse, an L-shaped recovery, unless we have an actual serious policy response to deal with problems of employment and jobs that were already there, that have just been worsened by what we've been seeing. So I'll leave it there. I think I kind of went a little over. Thanks for your time.
Yeah, thanks, Mike. Phil, before we move into your talk, your comments, I want to give us a chance to answer a couple of questions that I think are somewhat timely in this process of the hour. First of which is we do need a little more clarity about structural dynamics and their disproportionate impact on Black and Latinx communities. And we appreciate that question. That is a question that we know is an important part about how we understand the intersections of race and COVID-19. Sameena, can you address some of that for us? And then Mike, I'm going to ask you to talk a little bit about universal health care. We got another question out there about the role of universal health care, but Sameena, talk to us a little bit more about these structural dynamics, please.
I'll try to be quick, and I appreciate the question in part because this is where we're going. It is so tempting when people think about social determinants of health and disparities to blame communities of color for their own poor health. But like what we mean when we say there are structural factors there is that people are not resourced in order to pursue any kind of health-seeking behavior. If you are uninsured or underinsured and you have diabetes type 1 and are insulin dependent, or type 2, right? We are talking about hundreds of dollars that you have to pay out of pocket in order to fill a script. So we have families in Milwaukee and in other places where they might be splitting a prescription, right? Because there's simply not enough. You cannot manage your health. And with COVID-19, we know that pre-existing conditions make you more vulnerable. And so those pre-existing conditions are not equally distributed in our communities. I also want to be really clear that research shows time and time again that racism is another factor that negatively impacts people's health. The best examples we have of this, quite unfortunately, are in maternal death rates, right? So Black women giving birth in the state of Wisconsin and in the US generally are at higher risk of dying, not because of what they do, but because of the racism that they face on a daily basis, right? Which creates a stress response, for example, where they have elevated adrenal responses and cortisone responses because you're just keeping it tamped down all the time, and you become immunely compromised. We also have excellent documentation of what Donna Ayin Davis calls obstetric racism, right? So this is or medical racism. So when you encounter the healthcare system and you're asking for help, you might be discriminated against. And we know that this is tied to maternal death, women dying as a result of giving birth. So all those things were true before COVID-19. They're not going away. And I mean, class has a lot to do with it. So we're really seeing a lot of poverty, which again, doesn't have to do with people's choices. It has to do with opportunities and whether we as a society value those opportunities or not. So when we look at Milwaukee and the sort of growing hotspots on the South Side related to Latinx workers, we have a lot of people who are extremely precarious, are living from paycheck to paycheck, and simply don't have the luxury of not being out in public, right? These are all structural features. If we decided as a society, as crazy as it sounds, to just provide a basic income to different households, folks would be at home and they would be spending money. So I'll pause there.
Great. Thank you. Mike or Phil, either of you want to comment on any of these racial disparities and sort of the structural issues associated? You all want to add to that at all? Good. Cool. There's one more question and then Phil, we'll have you go. What does this mean for the potentiality associated with universal health care in the United States? Are we inevitably headed down that road? Does that even seem remotely possible given our healthcare industry? Can you all just provide a comment or two on that, and then we'll move into Phil's comments?
I think Phil should say something about
I was gonna let you take that, but I think
this is your area of expertise.
Well, I think that when we think about I'll say a bit about this in my talk, but when we think about the sort of the components of our economic growth model and the fact that our growth model depends so much on employment, and that when there are high levels of unemployment, the economy stops working. The same idiom applies when we think about healthcare. Our healthcare system is based on a model from the immediate post-war period of large firms with people with long employment tenures and very favorable conditions for employer purchasing of affordable healthcare. The rise in medical inflation and deindustrialization, deunionization in the late 1970s made that model fundamentally porous and vulnerable to collapse. So in one way or another, unless we are simply comfortable with the idea of more and more people accepting the totality of risk for things that they have no control over, and all of the costs associated with that, nothing is inevitable, of course. But I think the system that we've created has been collapsing since the 1970s. And this will probably, if anything, it accelerates and makes visible what was already an underlying trend.
Sure. Thank you very much. And that's a great intro that you've provided for yourself. Ladies and gentlemen, Dr. Philip Rocco, Department of Political Science. Phil, go ahead and jump into your comments, please.
Thanks, Rob. What I really want to do is kind of bring this down to the state and local level, because obviously over the past few weeks now, Wisconsin, in a sort of patchwork way, as we all know, is moving in one way or another to reopen itself. And so there are some facts on the ground that we need to be very closely attentive to when we think about what state and local officials can do to build a pandemic-ready society. So I'll go to the next slide, Ben. I want to bring this down to the sort of material level, because it's very, very easy, and I think there's a psychological impulse to deny what is in front of our eyes. Daniel Defoe, in his Journal of the Plague Year in 1665, know that municipal authorities in London refused to accept that there was anything unusual happening, and they tried to keep this information from the public until the spike in deaths made it so impossible to deny that the bubonic plague was around them that all they could do was lock people and families in their homes to stop the spread. So we should be very attentive to what's going on and resist the impulse to engage in wishful or magical thinking. So go to the next slide. We talk about a pandemic-ready society. I think we have to think not only about the public health response capacity, but the economic response capacity. As I said earlier, the U.S. economic growth model works as long as there's little unemployment, wages are being earned and spent, and credit is being recycled to cover the difference between wages and costs. The assumption is that prices and wages will adjust quickly, capital is going to be redeployed, and growth is going to return without the need for state intervention. That the real economy in a crisis like this will absorb damages through unemployment and austerity. But these are not normal circumstances. No matter what states do to reopen themselves, there's going to be no quick fix for the crisis. Most epidemiological models show a wintertime outbreak that is going to require extensive periods of social distancing if we want to avoid mass death. Go to the next slide. And so when we look at, this is the CBO unemployment projections. Already we've seen that 25.6 million fewer people are projected to be employed in the second quarter of 2020 than in the fourth quarter of 2019. But these are the big caveat on these numbers, is that the severity and duration of the pandemic are highly uncertain. This is not the I Love Lucy scene at the chocolate factory where the assembly line just speeds up and more chocolates come out. These are not just more chocolates. We have no idea what's coming out of the chute. And the policies that were being implemented right now are still evolving. And so models like this, I would just say take them with a big grain of salt in terms of how rosy their sort of economic projections are. And Ben, if you want to go to the next slide. I I actually can't see the slides now for some reason. Okay, they're there. So how has the US responded to this? Well, two very different responses. Obviously, the federal government is the primary entity that has the ability to do counter-cyclical policy. So it's offered relief primarily through discretionary programs that are going to sunset at some point and that Congress will have to reenact. Temporary enhancements to automatic stabilizers like unemployment insurance, SNAP, formerly known as food stamps, and Medicaid. Hopefully, a program of state and local aid, but it looks like the current bill that contained that program is dead on arrival in the Senate. So that is going to be something that we should watch. So what are state and local governments left to do? Well, if we just assume a baseline scenario, nothing much changes in the federal government. State and local governments have some options. They can draw on reserves. Those are quickly going to seize up. They can engage in austerity. $650 billion shortfall for state governments over the next 3 years if Congress doesn't act. And of course, they can engage in creative accounting, accelerated payment schedules, and things of that nature. Next slide. What does that mean for Wisconsin? Very, very different consequences, but all of a similar cast for state, county, and then cities and villages. 1 in 7 workers in Wisconsin is unemployed. Given that 58% of our general revenue is made up of income taxes, that's individual and corporate combined, that's a problem. Sales tax revenue is about 34% of the general fund. Again, lower demand creates a problem there. And then, of course, we have to think about this as unemployment increases, there's going to be increasing pressure on state financing of our key shock absorber programs like UI and Medicaid. At the county level and city and village level, there's a little bit of an insulator because obviously counties, cities, and villages depend a little bit more on property tax than the state government does. Now, that's not a permanent abeyance of the problem. As assessments on properties are going to be delayed, so that creates a sort of temporary buffer. But once those assessments are revised, property values are likely to diminish. The problem will be kicked into the future. In the immediate term, there's going to be impact on a few key revenue streams. In counties, sales tax in about 68 of the counties makes up about 8.1% of revenue. There are, of course, user fees as well. And really the impact, I think, at the city and village level is going to be on service charges that have become a greater part of municipal revenue. And I think there's going to be a larger impact on tourism-dependent jurisdictions that rely on revenue from hotel taxes and other sort of recreation taxes. So go to the next slide. So what can state and local officials do in this context? And I want to just sort of address what I think are two sort of misconceptions about state and local officials in the media. There's sort of one perception here, which is that state and local officials are heroes that have to be expected to creatively do anything in the midst of a crisis. On the other hand, I think there's a perception that state and local officials are sometimes just policy takers rather than policy makers. They're just at the mercy of whatever the federal government does. And I see both of these visions as fundamentally wrong. In a sense, I think that states and cities have a kind of improvisational capacity to respond. It's not, they're not heroes. Not everything that they need is fully within their grasp. But there are 3 things that they can do. Elevate key issues at the national level as partners in governing. Second, sort of rewriting the fiscal script and rethinking what the boundaries of state and local fiscal policy are. And then third, really creating models that the federal government can ultimately adopt for reform. So we'll go to the next slide. The first thing I think state and local officials should realize is that in the United States, we tend to treat state and local governments, at least in terms of their relationship to the federal government, as just another series of lobbying groups. And if you think about Congress's response, Congress put firms ahead of state and local governments. State and local governments are in many ways, I see it as at the back of the line in terms of bailouts. In other countries, this is not the case. Canada really views provincial governments as partners in governing through a series of formalized relationships. And so they're not just lobbyists like anybody else. We used to sort of do this in the United States through something called the Advisory Commission on Intergovernmental Relations. But state and local officials have an important voice that can be articulated in this crisis as partners in governing. And if you think about it, there are a few things that state and local officials can be pushing for. The first is a sort of an anti-recession fiscal assistance program. There's some proposals on the table for what is incorrectly being called bailouts to state and local governments. Anything that Congress does to provide financing to state and local governments isn't a bailout. It is an attempt to preserve the federal system as we know it. And so what state and local officials can push for is a transformation of the thinking here from emergency state and local aid into an automatic stabilizer, right? Recognizing that we have a fiscal crisis, state and local governments' inability to respond through monetary policy or sort of counter-cyclical policy has a huge effect. During the last few decades, cuts to state and local spending offset about 25% of the total stimulus provided by the federal government during a recession. So if the federal government can't provide aid to state and local governments, the pro-cyclical tendency of state and local financing is going to be a huge problem. State and local governments, I think, can also push for an expansion of the Federal Reserve's municipal liquidity facility, which currently has requirements for investment grade rating, and there's a cap on purchases. They can push for changes to those policies. Third, I think that if we think about where some of the fiscal stress comes for state and local officials, it comes through the unemployment system and the shock absorbers like Medicaid. A Paycheck Guarantee Act, which would allow employers, including state and local governments, to maintain 100% of base payroll and benefits, would remove a lot of the fiscal strain on Medicaid, unemployment insurance, and all of these other sort of programs which have to kick into gear when state governments and local governments are forced to respond to a crisis, which is why we've already seen in a number of states there being independent letters from state and local officials to Congress demanding action on the Paycheck Guarantee Act. Finally, I think we're going to get into a discussion probably about universalizing healthcare in a second, but I think at the very least, Congress can be pushed to federalize Medicaid financing and guarantee Medicare coverage for people who are uninsured or wouldn't qualify for Medicaid during the emergency. This would, at the very least, reduce what I would call the sort of state fiscal blood pressure and eliminate the need for budget-driven cuts to service and payment rates. So next slide. Second thing we can think about beyond just state and local governments becoming more effective advocates for these policies, which would have a huge impact on the national economic response, is that it might be necessary for state and local governments to rewrite the fiscal script. The problem, I think one major problem in terms of the financing piece is that local governments generally don't like to issue short maturity debt. And what happens when the Federal Reserve support dries up or when there's a sort of stopgap there? If you look at prior crises, if you look at the Great Depression, for example, state and local governments actually issued scrip in the form of tax receivable IOUs, most successfully in New Jersey and Michigan. These are, of course, acts of desperation. They can't prevent an economic depression, but since people can directly settle their local tax obligations with this kind of IOU, tax delinquencies that normally appear during these recessions don't increase because individuals can at least provide something of value in exchange for these notes, tax anticipation notes. So I think that we need to just rethink what the sort of boundaries of local and state fiscal policy are. Next slide. The third, and I think perhaps most important component of what state and local officials can do is remember that many of the most important models for federal reform that we sort of take for granted now, like unemployment insurance, Social Security, the income tax, started in fact at the state level, right? Both the income tax and unemployment insurance started in Wisconsin and then expanded to the national level. And so what state and local governments can do is think about, even if the reform that we develop now isn't successful at the state level or it doesn't remain there, it can become a powerful example that the federal government can later adopt. So how do you do this? Next slide. Oops, one before that. Okay, so what would this take, right? What are some steps that states can take to create models for federal reform? I think the first thing is to think about emergency investments where they're needed most. In Wisconsin, in DHS, for identifying, investigating, containing infections before they become clusters. Second, stabilizing but not cutting spending. Spending cuts during crises like this tend to be very poorly targeted, hasty, badly designed. And ultimately, if you think about why public health capacity in the United States is so poor, during the Great Recession, public health was one of the first things to be cut. So that's an important story here. Third, state governments should take full advantage of federal relief funds and especially the municipal liquidity facility to support pandemic relief operations and to really begin to rethink some aspects of what the public sector can do. The state has the ability to borrow now on historically favorable terms. Wisconsin can still float top-rated, investment-grade municipal securities, and I think the macroeconomic landscape sort of favors public debt. And I think finally, what we need to think about here is the long-term investments that will enable the state to address social issues that really preceded the crisis, but magnify vulnerability, things that Dr. Mulla and McCarthy already talked about. I think in particular homelessness and housing insecurity. I think about 4.5 thousand people were homeless in 2019. That's probably an undercount. And that creates, I think, a huge site of social risk for pandemics. So thinking about what these material conditions are and actually taking advantage of the resources that are available, both on the federal level and sort of rethinking what the boundaries of state fiscal policy are, would allow Wisconsin to be the sort of innovator that it's been in the past. Final slide. Just want to wrap up here with a bottom line, which is that state and local officials, they're not merely policy takers, right? They can be policy makers, not only because they have an important role to play in setting the agenda for federal reform as not just lobbyists or one other special interest, but as partners in the federal system, but also as fiscal policy innovators, rethinking what the boundaries of fiscal policy are, and as originators of policy ideas that meet the conditions on the ground. So with that, I will conclude.
Phil, thank you so very much. It kind of boils down to a real simple question, and that is, what is the role of government and who does it serve? Thank you so very much for that.
Thanks.
We've got one question to lead us into the Q&A. We know we are at the 1 o'clock period, and we also want to, of course, be mindful of folks' time. We want to give a 10 or so minute opportunity for folks to ask some other questions. We want to keep this first question keeps us in an international lens. Other countries have experienced similar kinds of disparities. Are there some countries that are doing this better in terms of mitigating those disparities, or are there some models out there that we ought to think about? Mike, you provided a commentary on that. That comes from John Sue. But this is an all play if anybody wants to jump in. Who's getting this response right, particularly as it relates to the racial and ethnic disparities?
I can jump in for a moment. And I mean, the question as I understood it is, are there places with lower levels of structural racism that are developing COVID-19 responses that don't reinforce existing disparities? And I think there are places with perhaps less racism where you have, more traditionally homogeneous ethnic populations. But even there, I mean, like we think about South Korea, there's a large immigrant population from all over South Asia. And there are still disparities. It boils down to who had an existing infrastructure in place, right? If we look at England or France, which we might think of as somewhat more heterogeneous, we are seeing the kind of disparate distribution of COVID-19 in, again, non-white racial communities and ethnic communities, lots of immigrant communities, especially if you drill down into the data in Paris and things like that. But generally, there were these existing infrastructures, right, like the NHS in place that could immediately be mobilized. Now, if we think about the South Korean response, which a lot of people like to hold up as a model, right, they're also using existing infrastructures, which aren't all necessarily related to healthcare. It's not popular to think about the response in Wuhan, but part of the reason it was so effective in some ways was because they had neighborhood level infrastructures in place, right, where people could seek services. There are also lots of experiments going on with basic income, which is being funneled through various kind of policy directives. So, you know, even funding firms has come with wage guarantees, which in England we see are going to kind of continue at least through mid-July. And those kinds of policy instruments, they're part of an infrastructure too, right? It's not just the material basis of what we have and buildings that we can mobilize, but it's, you know, what kind of policy tools can we throw into play? And so I don't want to paint a rosy picture of these other places because people are still suffering and falling ill. But if we look at infection rates, they are far lower in all of the places I just mentioned.
Right, right. Other folks want to jump in on that?
I could jump in. Some interesting research hasn't been published yet, but it's forthcoming by economists and sociologists at Columbia. Finds that in the U.S., access to PPE at the workplace is significantly correlated with unionization. And I think that gets to the issue of actual power as an employee and the ability to sort of demand conditions that give you a safe place to spend the entirety of your day. I mean, when we see places that are not hit as significantly in terms of deaths, places like Germany, where there's much more significant bargaining, more significant power to say, no, we're going to work differently. We're going to prioritize health over productive output, things like that. So I think that's one aspect of a way of answering that question, which is, you know, gets at the fact that many poor people of color don't have those kind of protections. They don't have those kinds of capacities at the workplace. They work in more precarious employment situations. They tend to be working in closer quarters with people in ways that can circulate the disease. At a global level, if you think back all the way back to the so-called Spanish flu, 1917, 1918, it was actually from Kansas. I don't know why we call it Spanish flu, but 60% of all of the people who died from the Kansas flu, we'll call it that, lived in India. They lived in cities that had massive slums. Only now are we seeing the spread of this disease into the less developed areas of the globe because of colonialism, because of a history of structural racism that has left these places without an infrastructure. That to me is the massive looming health crisis that is before us. That is, if this thing spreads like it spread in places like Spain and Italy and New York, in the slums of Brazil and the slums of India, slums of South Africa, I mean, that to me would have devastating consequences for health inequalities along racial lines.
Absolutely. Yeah, go ahead, Phil. You want to jump? You're muted.
I would just add one thing, which is that I think language matters a lot here, which is that we say the word public health, probably the image that comes into your mind is the public health department in your locality or state. Public health, I think, ends up being whatever government does or does not do to take care of the people who reside within its boundaries. So it's not surprising that there are states that are not counting the infection rates in prisons. There are countries that are not counting infection rates among migrant workers. This is really important not only because of who we count, but also because of what we think about as being public health. In the United States, our public health system, emphasis on scare quotes, is really just derived from a military series of maritime hospitals, and has been very, very fragmented from the rest of what we do that actually affects public health, how government gets information about health needs. The NHS integrates individual medicine and public health. Unionization and sectoral bargaining in other countries integrate information about workers' health needs with what government and employers are capable of doing to meet them. In the United States, all of those capacities are fragmented from one another. And so it's, I think there's this question of like, why are infection rates so high in the United States? That's overdetermined, right? But I think in a sense, it's a target-rich opportunity for thinking about what we can do. There are limitless things that we can do to avoid a circumstance like this in the future, and to even address what's going on right now.
Sure. Folks, in respect of time, we're going to go ahead and wrap this conversation up. And I think what I'll ask each of you is, it's probably in our best interest to continue having these conversations. And so over the next several months, we'll be back in touch with you on a regular basis to continue our conversations and continue updating where we are, and then also to dig into some of these threads with a little more detail. I think it's useful for us to think about some of the historical comparisons and get more of that information. I think we need to spend a little bit more time maybe thinking about what's happening in other parts of the world to really give those places a little more attention. I think we can dig into more of the politics and the economics, and to see how this develops both nationally and internationally. I think one important question is how this is impacting us at the state level, in our state level economies, whether it's with our farmers and our restaurateurs and everything else. And so we have any number of conversations that we ought to be having that can then supplement the conversations that are being had in other venues and other circles. I've got what looks to be one more question show up. Yes, our dean has given us advice. So we're going to be opening this up to other entities as well across campus. And Heather, we're going to share this broadly as well. So again, Sameena, Mike, Phil, thank you so very much for your time. Good job, Ben. Good job, Sam. We got Command Central in the backdrop helping us out. We will wrap this up, and we will have more of these conversations very soon. Please give these folks a virtual round of applause, and we'll wrap up. So thank you all very much.